I'd like to thank the organizers of the ALS Association in Argentina for asking me to give this talk. This is a particularly good time to talk about development of therapeutics in ALS because there's so much going on. I'm Jeremy Scheffner. I'm a neurologist in Phoenix, Arizona, and have been involved in ALS research for many years. In 1996, I started a group in the United States called the Northeast ALS Clinical Trials Consortium, which over the last couple of decades has really been quite important in running trials and in developing new ways to organize clinical trials in ALS. I've also been the principal investigator of a number of large national and international trials of different therapeutics in ALS. So this has been a passion of mine for many years. Today, I'm going to talk about where we are in ALS therapeutics and hopefully some thoughts about where we might be going. I'm going to share my screen. So as I mentioned just a minute ago, I'm going to talk about where things stand with regard to ALS clinical trials. And I go back a little bit in time because this has been an exciting 6 or 7 years, and review with you some of the ways that I think we've reached a knowledge of effectiveness of different drugs, talk about some recent events, and then maybe talk a little bit about how the sort of science of clinical trials has evolved over the last few years. I have been consulting with a number of small biotech companies to help them develop drugs in ALS and guide their clinical trial designs. And so here are my disclosures. And this is sort of the background of what I'd like to discuss over the next few minutes. The last 7 years has been completely different than the 25 years before that in terms of our progress in both finding potentially really important drugs for treatment of ALS patients, but also how we have performed trials. And so, as I'm sure most of you know, in 2016, the United States FDA approved a drug called edaravone, or Radicava in the United States, for treatment of ALS. And this was a surprising development for a number of reasons. One was that the way the trial was set up was completely different than prior trials, in that the trial that really resulted in FDA approval was a very small trial, only 136 patients, which is far different than the hundreds and hundreds of patients that had been studied in the past. And so I'll talk about how this company approached clinical trial design and what we learned. I think as a direct result of that development program, the Amylyx Pharmaceuticals developed a drug that's a combination of two component drugs, toroursodiol and sodium phenylbutyrate. And this was also approved on the basis of a very small trial, about the same size as the one that led to the approval of edaravone or Radicava. Just last week, or 2 weeks ago now, the US FDA approved an antisense oligonucleotide drug, which is a novel way of designing drugs, called tofersen, to treat a subset of patients with ALS, those with mutations in the superoxide dismutase gene that leads to an inherited form of ALS. And this trial and development program was also relatively small, as it needed to be, because this is a very rare form of ALS, and I will talk about that as well. On the negative note, very recently we also saw the discontinuation of a large phase 2 trial of a drug called Reldesemtiv, which was intended to increase the efficiency of muscle contraction and so make people with ALS stronger for longer periods of time. And this was particularly disturbing to me because I have been involved in developing this kind of compound for many, many years. But it was also disturbing in ways that I'll talk about in a little bit, in that this, I thought, was a really good example of intelligent and rational trial design, with trials based on information from basic science, as well as clinical studies that really suggested the effectiveness of this approach. And so it really has caused me, and I think others, to step back and think about how we develop drugs. So in that context, I'm going to talk about how we are really thinking about trials in the future. How big do they have to be? How predictive are single small trials, no matter how encouraging the results? How long trials need to be? That's in particular relevant to the tofersen clinical program, which initially was basing decisions on pretty short periods of time, 6 months or less, but which I think really gained approval because of a much longer term trial. What kind of outcome measures should we be using when we design trials? Most trials going on now and in the recent past have used the ALS Functional Rating Scale Revised, which is a 12-item rating scale, as the primary outcome measure. But there are reasons to be looking at other measures that might be more sensitive, might be more amenable to making trials easier for participants in the trials. And I'll spend some time talking about that. So these two figures really summarize the development program of edaravone, or what's called Radicava in the United States. The first trial, which is summarized on the left-hand side, was another small trial, about 136 patients, treating patients with ALS for 6 months with either Radicava or edaravone or placebo. While there were, I think, very promising signs from this small trial, it was not positive. There was no statistically significant change between the placebo-treated patients and the edaravone-treated patients. And so the organizers of the trial went back and looked to see whether there were subpopulations of participants that seemed to show a better response to edaravone than others. And so one way they looked at it was in the diagnosis category of the patients who participated in the trial. Now, for research purposes, patients are diagnosed with ALS according to what are called the LS-Goriel criteria. And they have different categories of diagnosis. Definite ALS refers to people who have signs or symptoms of ALS essentially throughout the entire body. People with probable ALS have signs or symptoms of ALS in what we define as 2 body regions. And we divide the body for this purpose into the muscles in the face, the muscles that are connected by spinal nerves coming from the neck, which are the arms, the thoracic region, which is the abdomen and back, and the legs, or the lumbosacral region, which are connected to the spinal cord through nerves coming through the lower part of the back. And so probable ALS refers to patients who have signs or symptoms in 2 out of those 4 body areas. And then finally, probable laboratory-supported ALS is the same 2 body areas, but also brings in electrical measures of nerve excitability and muscle function. So it's the least diffuse kind of ALS. And so if you look at this figure, the hatched areas are the response of patients treated with edaravone as compared to the dotted bars, which are placebos. And if you go from left to right, the patients who were diagnosed at baseline with definite ALS, or the most diffuse ALS, had the biggest change between the placebo group and the treated group of 2 points in the ALS scale, ALS-FRS scale, over the 6-month period of the trial. The patients with probable ALS had a little bit less than a 1-point change. You can see that the difference between the two sets of bars is less. And then the patients with probable laboratory-supported ALS on the right showed only a tiny change between edaravone and the placebo group. So fast forward another 3 or 4 years, and the results on the right were found. And this is another study of 136 patients. But if you look at all of the patients in that study, by the end of 6 months, there was a change of about 2.5 points in the ALS functional rating scale, which is a change in the rate of progression in these patients of about a third. So patients on edaravone were changing about 1/3 to 2/3 as fast as those in the placebo group. And this was statistically significant, and most of the people who participated in the trial thought this was clinically important as well. So how did they do that? And the next slide really describes what the differences in the two trials were. And they mostly had to do with inclusion criteria, who was allowed to be enrolled in the trial. As I mentioned, in the phase 2 trial, the diagnosis categories of definite, probable, and laboratory supported probable ALS all those patients were included in this trial. Patients had to have a breathing capacity of 70% of predicted or more, and a disease duration of less than 3 years from the start of the trial. So fairly broad criteria. Many different kinds of patients were included. Based on the results that I just talked about, the trial that led to the approval of edaravone was much more specific in the kinds of patients they enrolled. More importantly, they enrolled only patients with definite or probable ALS. That means the people who had the biggest effect in the last trial. They enrolled people with a higher breathing capacity, so presumably earlier in disease. And they also only allowed people to participate in the trial if they had had symptoms for less than 2 years. So what that did was selected for people earlier in the disease onset, in their disease course, who are also likely to be progressing more rapidly. And the numbers in red show that. So if you look at the rate of decline, or the number of ALS-FRS points that patients declined in the placebo group, in the first trial, the placebo patients declined by about 6.35 points. But in the second trial, which was more restrictive, looking for faster progressing patients, that decline was 7.5 points. So significantly faster progression rate. And because of that, the effect of edaravone was allowed to be seen more effectively. And so the difference between the placebo group and the edaravone group was greater and statistically more impressive. So that's the development strategy that led to edaravone's approval. The next drug that was approved, which was just last year, was the drug that was developed by the company called Amylyx, which is called Relivrio in the United States. And it's that combination of two drugs I mentioned before. And the next slide shows how that study was designed. And I was part of that development group, and we took the lessons from the previous study and applied them even in a more stringent way. So in this study, only patients with definite ALS, or the most diffuse kind of ALS, were included in the trial, and only people who had had symptoms or signs for less than 1.5 years were included in the trial. And the result of that was a group of people that declined over the 6-month periods of the trial even faster than the people in the edaravone study. And so the first number in red, 9.97, or nearly 10, is the number of points that people in the placebo group declined over the 6-month period in the Amylyx study. And again, this is almost twice as fast as the people in the first edaravone study, and allowed a relatively small effect to be seen as statistically significant. And the results are shown here. And so on the left is the change in the ALS-FRS over time in the Amylyx study. And the difference between the placebo group and the treated group was 2.3 points in the ALS functional rating scale, about a 25% slowing in the rate of progression, which was highly statistically significant, and also was associated with a pretty surprising impact on survival. So this was another novel thing that was done for this study. So after 6 months of placebo-controlled treatment, all of the patients who participated in the trial and completed it successfully were offered the opportunity to continue taking active treatment or the actual medication for an indefinite period of time. And many patients took it for up to 3 years. And so the survival curves shown on the right show, if you look at the middle, at the horizontal line at 0.5, that's the time at which, the time at which approximately half the patients experienced a survival endpoint. About half the patients died. And you can see that in the patients originally randomized to active treatment, those patients lived about 24 months, as opposed to the placebo group, which lived about 18 months, a pretty significant change in survival. And this was able to be measured because everybody in this study was followed for survival. They didn't lose any patients in terms of loss of follow-up. So these two data points led to the approval of the drug taurursodiol and sodium phenylbutyrate, or Relivrio. So other drugs have been approved, have been studied during this time, and just 2 weeks ago, the FDA approved the use of a drug called tofersen for patients with superoxide dismutase mutations that cause their ALS. Tofersen is something called an antisense oligonucleotide. And what this is basically a designer drug that looks like DNA and attaches to the molecule that really codes proteins in the body, which are called RNAs, and reduces the production of this mutant protein, or this mutant SOD1. And this, in the original study, which was a very small study in patients who had very aggressive ALS caused by this SOD1 mutation, suggested that for those kinds of aggressive patients, there was a pretty dramatic change in progression, or that was thought to be pretty fast over the course of 3 months. And so the phase 3 trial, which was called Valor, actually selected for their primary outcome a group of patients that the organizers thought were progressing quite rapidly. And those are the patients in red on the graph on the left. But it turned out that, at least compared to the two previous studies, the edaravone study and the Amylyx study, these patients didn't progress rapidly at all. Over 6 months, they progressed by about 6 points, which was the rate of progression of the first edaravone study. So they made a mistake in how they thought patients were going to progress. So the graph on the left looks at patients who were thought to be fast progressing in the red, and patients who were thought to be slower progressing in the blue. And they certainly did find patients that were slower progressing in the blue. And the difference between the solid curves and the dotted line curves are the difference between placebo and tofersen. And both the rapidly progressing patients and the slower progressing patients actually looked somewhat better than the placebo, but only mildly so. So the graph on the right shows what happened after all the patients after 6 months were offered treatment with tofersen. And at least for the slow progressing patients, and to some extent the fast progressing patients, there seemed to be an increase in the difference over time. And so the organizers went back, and instead of trying to divide people into what they thought were fast and slow progressing groups, they looked at everybody. And they found that if you looked at everybody, and on the top left is the change in the ALS FRSR over time, that if you looked at them even after everybody was taking the active treatment, the difference between placebo group and the treated group originally got bigger and bigger. And it actually looks like after a period of time of about 8 months or so, people almost stopped progressing entirely. That same trend was shown when they looked at the breathing function, which is the bottom left, that there was a difference at 28 weeks. But after a period of time of almost a year, it appears that the last 6 months, people aren't changing at all. And the same thing looked to be true for strength, which is handheld dynamometry, which is the top right. So after a longer period of time than they thought was going to be necessary to see an effect, they saw what looks like a pretty dramatic effect. They also looked at a biomarker called neurofilament. Neurofilament is something that's present in neurons and is released into the spinal fluid and into the blood when nerve cells die and get broken up and ultimately degenerate. And so what they found, if you look at the green curve are the people who were started on tofersen from the beginning. They found that the level of neurofilament was dropped by about half at the 28-week period. And that drop continued over the course of a year. For the patients on placebo, which are the dotted lines, there was, if anything, a slight increase in neurofilament in the first 6 months. But as soon as these people were put on open label tofersen, those people dropped in their neurofilament as well. And so one of the things we think about when we try to design trials are the question of, are there markers of nerve damage or nerve degeneration that we can use to really get a signal of effectiveness in an earlier way? And it looks like neurofilament could be a really promising way of evaluating ALS patients over time. And the approval of tofersen by the FDA was in large part due to this change in this fluid biomarker. So just to review what we know about neurofilament, it's a marker of neurodegeneration, and it can be measured both in the spinal fluid and blood. We know that ALS patients have higher levels of neurofilament in their blood or spinal fluid than healthy control patients do. And people with ALS and the highest levels of neurofilament seem to progress more rapidly than others. We know that in other diseases, if drugs reduce neurofilament, those drugs tend to be effective in those diseases. And that's true in a disease called multiple sclerosis. It's true in a childhood onset motor neuron disease called spinal muscular atrophy, and it appears to be true in ALS as well. Interestingly, though, some treatments that do show a clinical impact don't change neurofilament. And in particular, it's the Amylyx drug did not show any change in neurofilament. So we don't necessarily think the neurofilament change is exactly the same as a clinical impact, but we think it's a very important marker for the future. So I think we learned a number of things from this development program. One is that even with genetic information, it's hard to predict the ALS progression rate in people participating in a study. The tofersen program really did that quite poorly. It may take longer than 6 months for an effective drug to show an effect. And so we really do need to think about how long trials should be, and we should think about that based on how effective we think the drugs are and when we expect them to exert an effect. And we also really learned a lot about neurofilament in designing future trials. I now want to touch on on this drug called Reldesemtiv, which I think we had very high hopes for, but was recently stopped because an independent safety monitoring board realized that the study had really no chance of showing a positive clinical effect. Reldesemtiv was a drug that clearly increased the efficiency of muscle contraction. We could see that in animal models, and we could see that in normal volunteers. And it was the subject of 5 different phase 1 and phase 2 clinical studies. And I'm going to show you the biggest one that led to the trial that was just stopped. But first, this is the one of the ways that we really got information about Reldesemtiv. If you look at the cartoon in the top right, in this experiment, people had a nerve stimulated at the knee that causes the ankle to go up. We call it dorsiflexion, but the ankle bends up in an angle. And if you look at the curves on the left-hand side below the word Reldesemtiv, the nerve was stimulated at different rates of stimulation, from 5 stimuli per second up to 25 stimuli per second. And the different green bars are the extent to which normal humans saw the force of contraction of this muscle increased at different concentrations of Reldesemtiv. So pretty strong evidence that strength could be improved by this drug. There was a very large phase 2 study with about 450 patients receiving either placebo or one of 3 doses of Reldesemtiv, and it showed really promising results. And it's worth looking at them, even though the drug turned out to be unsuccessful. If you look at the top left, or the left-hand side, patients receiving Reldesemtiv declined in their ALS functional rating scale about 25% slower. Those same people declined in their breathing capacity by about 25% slower, and strength was declining about 21% slower. So pretty consistent, statistically significant changes in ALS outcomes that we think are important. So the phase 3 trial was intended to be a little bit larger, to look at the same kinds of outcomes over 6 months of study. But after 300 participants completed 6 months, it was found that there was absolutely no difference between the treated patients and the untreated patients in all of these measures. So the trial was stopped because of that. And so this actually was distressing to me, and for a variety of reasons. One is that I thought this was a really powerful and encouraging drug for ALS patients, but also that a large phase 2 trial didn't necessarily predict successful outcomes in a phase 3 trial. So what does that say about trials in the future? And what have we learned from these 4 development programs? One is, in general, using inclusion criteria, the kinds of patients we enroll in a trial, is a very effective way to ensure that the patients that you enroll are going to change in a way that you can predict pretty well. The length of time that patients have to be in a trial should really depend on how we think of the mechanism of action of the experimental drug, and how long we think it should take for that drug to exert an effect. And how we measure ALS is very important. The ALSFRS is a good measure, but neurofilament is something that provides complementary measures. And there are reasons to keep searching for measures that are even more sensitive and will allow our trials to be more efficient and effective. And I'm going to finish the talk talking about a couple of those. First, the ALSFRS-R is really something that's been used now for several decades, and we know a lot about it. First, it's reliable. Second, we can actually perform the assessment on a video call, so that patients don't necessarily have to come to the clinic if that's inconvenient or if they live far away. And in general, when the ALSFRS is impacted by study medication, those impacts are also seen in strength and in breathing capacity and in other measures. So it seems to correlate with many other good measures. But there are reasons to look at others, and I just want to talk about one other class, which are measures that you can assess at home. Why do we care about that? Well, as trials study patients who tend to get worse over time, it gets harder and harder for patients to come into a study center for their evaluation. And if we could measure things at home, that might make it much easier for patients to continue to participate, reduce dropout, and really increase the attractiveness of clinical trials. And in general, we also know from COVID that things can happen not related to ALS that can really change people's ability to get to a hospital or a clinical study site. And so good measures at home could be very important for ALS trials in the future. Another advantage of measuring things at home is that you can measure them more frequently. And I don't want to go into this slide in too much detail, but what this slide shows is that the more frequently you measure almost anything, the more reliable you can be, more confident you can be in any individual patient's rate of decline. And we did a study of this, measuring a bunch of different things. And we asked people to measure their scores daily for about 3 months, and then twice weekly after that. And we measured, in this slide, it's a busy slide, we measured an indicator of muscle function called electrical impedance myography, or EIM, that's at the top. We measured hand grit strength just with a digital hand meter that we sent to patients and let them do that on their own. We measured breathing capacity with a device that we could send to patients and again have them do that on their own. We gave people a smartwatch or an activity band and had people just wear them and measure the level of activity. And we also had people measure their own ALSFRS. And then we looked at what the data looked like if you measured things every day, twice a week, every week, twice a month, and monthly. And the gray shaded areas around the individual lines reflect the level of certainty that we have about the rate of decline of any of these measures. And the important thing is that if you go from left to right, those gray areas get bigger and bigger, meaning that you get less and less certainty about how an individual person is progressing. So frequent measurements could actually be a very powerful tool. One thing that we can measure at home quite easily is a measure of speech. And so we developed a measure of speech that actually was an app that you could install on a smartphone that measured how fast people were speaking, how precisely they were speaking, how well their tongue and lips moved in terms of making specific sounds. And when we did that, we found that we could actually take these measures and predict how people reported their speech were. And this is a measurement of the single ALS functional rating scale question that rates speech, with 0 meaning no functional speech at the bottom and 4 meaning normal speech. And so on the x-axis at the bottom is the actual ALS-FRS-R score, and on the y-axis is the predicted speech score based on these measures of speech. And the point of this slide is to show that actually we predict speech very well with this speech measurement. And we can also tell the difference between people who think their speech is normal, but they have ALS, and people who are actually healthy controls. And just the point of this slide is just to show that the blue circles are the people with ALS, the black circles are the people who are normal controls. And even though these patients all thought their speech was normal, this speech analysis program can show the difference. So that's something that we can do at home. It's something that I think can potentially increase the sensitivity of future trials. And so what I've tried to do in this talk is sort of give you a history of where we've been over the last 5 or 6 years, what are recent findings, but also how we might be more efficient about studying drugs in the future. And I'm happy to take questions.
Thank you, Dr. Scheffner. That was excellent. Thank you so much for that. That was really interesting, really useful. I'm sure everyone can take really positive conclusions after watching this presentation. So I have a couple of questions here that we can address now. So the first question would be, now that the Reldesemtiv trial is over, is there any new way we can redefine or redesign Reldesemtiv in order to try to make it successful next time?
Well, that's always a question, and I can't answer this for sure, but unfortunately, I'd say probably not. So Reldesemtiv is the second version of a drug that was intended to do the same thing, which is to uh, really improve the efficiency of muscle contraction. And that first drug, which was called tirasemtiv, was promising, but it had a lot of side effects and wasn't quite as potent as reldesemtiv. And so reldesemtiv was designed after the trials of tirasemtiv were promising but didn't show statistically significant outcomes. And it was designed to be more potent and to be well tolerated. And both of those turned out to be true. It was more potent in both animal studies and in studies of normal human volunteers. And it was pretty well tolerated. And it didn't show any impact whatsoever. So I can't tell you that I understand why, but I think that we've done a good job of really studying this mechanism as best as we can in ALS. And for reasons that I can't really tell you because I don't understand them myself, it didn't turn out to be effective. That still makes the trial worthwhile because I think it really does mean we can concentrate on other ways of changing ALS. But I do think that it's likely that was the Reldesemtiv study that was just stopped is probably the last study of that kind of a medication in ALS.
Got it. Yes. Thank you. Now the next question. Do you think platform trials might be the new way of trying new things? Because it looks like if any of these regimens happen to fail after a while, it doesn't look like the harm is going to be that impactful because the trial keeps moving on with the new compounds that keep coming in, right?
Sure.
So do you think it is the new way to make everything faster and more effective in terms of trial design?
Well, thank you. I mean, that you bring up the platform trial, which I think is one I didn't discuss today, but I do think is a major innovation. And so just to review what that means, the Niels Consortium and the Healy Center for ALS at Mass General has started a way of performing clinical trials that we think should be really much more efficient and allow us to study more drugs faster. And so that is basically the idea behind a platform trial is that you have a standard trial design so that you determine who are the patients you want to recruit, how long you study them for, what you measure, and you do the same trial over and over again, but using different drugs. And so one of the big delays in starting a clinical trial is sort of recruiting your team so you have to identify the sites, you have to train the sites, you have to get all of everything approved by institutional review boards or ethics boards. It takes a long time. And if you have an ongoing trial that's always approved and that the questions of trial design are already answered because they're all pretty much standard, you can go much faster. The other advantage of a platform trial is that if all of the different arms of the trial are the same in terms of the types of patients you recruit, you can use the placebo group from one regimen to add to the placebo group of the regimen that you're studying, by itself. And so you can actually have far fewer placebo patients because you can borrow the different placebos from the different drugs that are being tested. So I think it's a very attractive way to do things. So far, it's been very successful in that we have studied 4 drugs so far, with the 5th one finished enrollment in the next couple of weeks, and now 6, 7, and 8 already on tap in about 2 years, which is far faster than any group has been able to do in the future. I wish I could say that translated into, dramatically positive results, and it hasn't. But that's sort of a feature of ALS is that we try lots of things and we don't know what's going to work. And so the platform trial allows us to try more things in a faster way with fewer patients having to be exposed to drugs that may not work. And so I think it's a real positive. I don't think it's going to be adopted for every single potential drug. And there are a number of reasons for that. And one reason is that different drugs might, at least theoretically, affect different kinds of patients in different ways. And so the platform trial depends on everybody being the same in terms of how they're being recruited. So if you have a drug that, certainly a genetic drug like the SOD1 drug, or if we had a drug that affect other genetic causes of ALS, that wouldn't make sense to study in the platform because you'd only want to look at patients with that mutation. If you had a study that you thought, if you had a drug that you thought was going to be particularly effective on breathing or on speaking or on swallowing, you'd want to pick patients that had those kinds of issues that you could look at change over time, and may not be the exact same patients that would be appropriate for other trials. So there'll be those kinds of studies that I think aren't going to be really amenable to a platform study. But overall, I think it's a great effort. I think it really has helped us be more efficient, and I'm hopeful that it will also, bring us positive drugs in the near future.
Yep, it makes a lot of sense. And in a couple of days, we're going to be having an interview, a talk with Dr. Paganoni.
Oh,
She's going
great.
to
So
be
she'll,
talking about the Healy platform, the last updates of the Healy platform.
yeah.
Yes.
Well, that's great.
So
She's certainly the person to talk to in that regard.
absolutely. Yeah, yeah. We have talked to Dr. Paganoni before, and she's great. Yeah, absolutely. So now that we have four ALS drugs approved, at least in some regions of the world, and I guess we have a pretty good understanding of how effective they are. Maybe not a complete understanding, but we have a pretty approximate understanding of that. When do you think we are going to know what the effectiveness is going to be of the combination of this cocktail of drugs? I know that's not an easy question, but
No,
that's what many people would like to know, of course.
it's a critical question, and clearly the drugs for people with sporadic ALS, Riluzole, which was approved in the 1990s, Edaravone and Relivrio, none of them are home runs. None of them take the disease and either make people better or stop progression. And so it's a logical question. If you have a bunch of drugs that have, say, maybe a 25 to 30% effect, how good could they be if you gave them all together? And theoretically, you wouldn't want to do that if the drugs had almost the same mechanisms of action, because you would basically be giving just effectively a higher dose, and that might not be an effective thing to do. But so far, the three drugs that we think have different mechanisms of action, and so it makes sense to think about their combination. The trouble is doing that study, and ALS is not the only disease that's had trouble with this. One problem is that those three drugs are owned by three different companies, and it's not necessarily in those companies' interest in supporting a trial to evaluate the effectiveness of their competitors' drugs. That's one problem. The other problem is that it's logistically very complicated. So you don't want to know just about whether all three drugs are better than any one alone. You want to know about the combinations of any two drugs. And so if you think about how you would design a trial, you would potentially design a trial with three groups, one getting each of the three drugs by themselves, three other groups getting each of the three combinations, and then a seventh group that's getting all three together. And then an eighth group that would be a placebo. Number one, it's almost impossible. You wouldn't want to do the placebo study because it's in essence unethical, because we know these drugs work. So you get rid of that one. But still, it's a lot of different groups that you have to organize. You have to have people being willing to take one of these drugs but not the others. And since these drugs are potentially available, will there be participants willing to not take a drug that they think works if they could get their doctor to prescribe it? So that's not to say we shouldn't try to study it, but it's quite difficult. My guess is actually that we're not going to learn about the combination by doing a trial like I just described. That we'll learn about combinations by sort of experiments of nature, that we're going to hopefully have people going forward who are taking one drug over time, or taking two of the drugs over the time, or taking all three. And as we learn more and more about these patients in terms of how long they survive, how well they're doing, we can compare these people even though we're not formally studying them in a clinical trial. And I hope that that will be helpful. But the same question is, has been addressed for Alzheimer's drugs or Parkinson's drugs or multiple sclerosis drugs. It's proved very difficult to directly compare one effective drug against another. So it's a big problem, but it's one we have to solve.
I would say that this is probably one of the last questions. With respect to tofersen, and we also have another trial that is testing tofersen with pre-symptomatic patients. So, what is the message for all of us who are or were relatives to people living with ALS? Should we all test for SOD1? Does it make more sense now that we have an effective drug approved for that specific ALS type?
Well, I would be a little bit more broad than that and say that everybody with ALS should have genetic testing, not just for ALS, but for the other genetic mutations. And recognizing that right now the only effective medication that's been shown is for SOD1. There are ongoing trials now in C9orf72 patients. There are ongoing trials in a more rare mutation called FUS. And I think, I think the landscape for people with inherited ALS mutations is going to be changing much faster, potentially, than for people with sporadic ALS. I think these drugs will be available and be shown to be effective over the next, I hope, fairly small number of years. So I think it definitely makes sense for relatives to know their status. Now, the Biogen study with tofersen that you mentioned, looking at pre-symptomatic patients, is a critical one. In that we don't know whether these drugs are effective in delaying the onset of ALS if they're given before symptoms. If they are, then it's a whole new world in terms of, you want to know absolutely as soon as possible and potentially be on treatment as soon as possible. But we don't know that yet. But regardless of that question, if you're a member of a family that has ALS in your family, you want to know that because you want to be alert to the first sign of change, either to enroll in a clinical trial or hopefully in the near future to take an effective medication. So I think there's no question that it's important for every ALS patient to know their genetic status. It's going to help them personally, but it will also help the development of drugs to impact the disease for people with specific mutations.
Got it. Okay, to close this presentation, can you tell us in a nutshell what projects you are involved in right now, that the ones that bring you more excitement, and the ones that make you feel more positive about them?
Sure. Well, I think that the platform study that we just talked about, which I'm heavily involved in, is a very exciting project. I think there are at least one drug that has come out of that that is quite promising, and I hope that drug, which is the drug called prodopidine, and developed by a company called Prolinea, I think that has a chance of really being an important drug in ALS and should be further studied. I think that there's a sort of a new physiology finding that I think is really being the source of lots of new drugs affecting this target. So in people without inherited ALS, something that happens to in their motor neurons is the accumulation of a protein called TDP-43. And it appears that in patients with sporadic ALS, this protein, which should be in the nucleus, one specific part of the cell, no longer is in the nucleus, but clumps in a very abnormal way. So there's like these protein clumps in the cell bodies that probably are a source of toxicity. And it turns out that there is another protein called stathmin-2, which regulates this event. And by altering how stathmin-2 is expressed in the nerve cells, we can change both how TDP-43 gets mislocalized from one part of the cell to another, but also, at least in experimental models, that dramatically changes how these models do, how the animals with experimental ALS do. And so there are lots of drugs now that are targeting stathmin in one way or another, or TDP-43 in one way or another. And I think if I was going to choose one kind of strategy for experimental trials in ALS, the drugs that I think are potentially the most optimistic ones are the ones that have this as a target. And there already are drugs in clinical trials that have this target, and there are others now just about to start clinical trials. And so I would say that strategy is the one that I'm probably the most excited about right now.
Okay, I think that will be it. Dr.
Good.
Schaffner, thank you so very much for taking some part of your very busy schedule to make this presentation for the ALS community in Argentina and the rest of the Spanish-speaking world. We will be sharing this presentation very soon. We will be editing this, and we will share it with you and with the rest of our folks around the world. Okay.
Thank you. I enjoyed it.
Thank you so much again. I hope I'll see you soon, probably in Basel in December. I don't know,
Good.
maybe.
Well, I'll be there for sure.
We will be there too, as well,
Good.
of course. So on behalf of the ALS Association of Argentina, thank you so much, Dr. Schaffner, for this presentation. It's been really interesting and with really, really important information for our patients and carers and the rest of the stakeholders.
Good. Well, thank you very much.
Thank you so much.
Take care.
Bye, Dr. Schaffner.
Bye-bye.
Thank you. Take care.